Merci beaucoup. Et merci à nos hôtes. Luxembourg est aussi le centre de comité olympique réforme pour l'hébergement. C'est une excellente conférence sur prévention. OK, Suzanne? Okay. I'm going to change to English now for obvious reasons. I want to just say that it's just really a pleasure to hear from so many different people from all over the world who are really interested in prevention and doing lots of amazing things. And I think we all know this is a multifactorial problem. It's a multifactorial approach. We use fantastic qualitative methods and quantitative methods to really raise the bar and to be able to scale up our efforts to have an impact. And today I was asked to talk about one aspect of that multifactorial approach. So I just wanted to start by saying that. And the work I do is focused on youth. And in Canada, based on our data, we expect 1 in 3 youth will seek medical attention each year for a sport-related injury. Lower extremity injuries are actually our biggest problem, 60%. Concussions actually only account in some sports for about 20% of injuries. In some of the sports we work with in Canada, though, they do account for more than 50% of the injuries. So it's important to consider all of the injuries, whether we're talking about concussions, ACL injuries, or ischio-jambier. So the greatest proportion of injuries in our country, that meant hamstring, Kay.
Thank you.
Yeah, no problem. So the greatest proportion in our part of the world in youth occur in basketball, ice hockey, soccer, skiing, and snowboarding. And we know there's longer term consequences, and there's lots of people in this room that are doing really important work around the impact on physical activity, overweight and obesity, psychosocial consequences, and mental health. Osteoarthritis, post-traumatic osteoarthritis following joint injuries. We talked about the economic burden earlier today. Really important to align this with studies so that we can understand with economic evaluations also the impact this has in our communities as well as at an individual level. So we heard a little bit about surveillance already from our first speaker, so thank you for that. And much of the work that we do is really inherent in surveillance, and some of the examples that I will be talking with you today about policy and rule evaluation have been evaluated with injury surveillance methods, but also with video analysis and sometimes instrumented mouth guards. So when we're doing injury surveillance, we call ours SHRED injuries, or surveillance in high schools and community sport to reduce injuries and consequences, and with a youth focus. It's really a research study. It's a longitudinal, typically cohort study, where we can evaluate prevention strategies that may occur naturally, and or we can embed this type of a tool within the context of a randomized controlled trial in some contexts. Ideally, that surveillance is also embedded within your clinical partnerships so that that information can be used to make clinical decisions. But most importantly, in the context of prevention and primary prevention upstream, so that we can move that data to inform practical changes in the communities that our kids are playing sport in, whether it be schools and or in clubs. So the question is, should this be a standard of practice? And if it should be, we've got to figure out how to sustain that. We've been fairly successful in this room, I expect, with getting research dollars to do the work often. That informs impact, but the long-term sustainability is another matter. So you've heard from lots of people around those important partnerships to support the research, but also to support that translation to impact. And so I think the key thing that has helped many of us be successful in the work we're doing in moving that research perhaps to impact quicker than 17 years is really about having the decision makers in the room, the community partners in the room when we're doing the research from the beginning. Are we asking the right questions? Are we collecting the data in a way that works for them? And then, of course, the dissemination at the end of the project. So in Canada, we call those individuals knowledge brokers. And actually, we typically, when we write a grant, we include funding for a knowledge broker. So somebody from the community club or somebody from the school who sits with our research team, and we fund them for that time so that we can sustain that throughout the project. And then some of our partners, of course, are not from sport associations or schools. They're also our clinical partners who support the surveillance component, including physicians who are in our program very active in supporting the evaluation and diagnosis of concussion so we can validate our outcomes with the surveillance. So I'm going to take you back a little ways. This is in 2010, there were 2 studies done, one by Brian Benson in the NHL at the same time as a study we completed in 11 and 12-year-olds. And I think that people were quite shocked to see that the rates of concussion were quite similar in these 2 groups. And I think that was a huge public health impact that needed to be addressed in 11 and 12-year-olds. If you haven't watched ice hockey before the 2013 Hockey Canada change, that is a body check against the boards. There's going to be an open ice hit here as well, and these are 11 and 12-year-old players. This is after a policy change that disallows body checking the same age group just now in the 2013-14 season. Many of you have probably, who's watched the women's game at the Olympic level? A couple people in the room, that's it. So in Canada, you would see many more hands. It's like brushing your teeth every day. Anyway, so in terms of ice hockey, at a high level in the women's game, there's technically no body checking, but of course we see a lot of body checking in the game. And this is removing the player from the puck, typically moving in an opposite or perpendicular position to the player who is possession of the puck. So there's, like any skill, there's stages of development. The 4th step of body checking skill is actually the body check, but typically you start at a very young age and you're working through positioning and angling, stick checks, body contact, probably not dissimilar from teaching the tackle in other sports such as rugby. And so what we're talking about is disallowing the body check in a game setting. They're still developing the skill when they are young so that they are prepared for when they are potentially playing at a level where body checking is allowed. So when we go back and take a look at some of the early work, what we found was that we had a 4-fold greater risk of concussion in players who lived in my province, which was Alberta, compared to in Suzanne's province, which is Quebec, because we allowed kids in 11 and 12-year-old ice hockey in leagues to body check, whereas it was delayed the body checking until age 13 in Quebec. And so we see overall a 3-fold higher rate of all injuries, including hamstrings, in the Alberta, whereas we see a 4-fold greater risk of concussion. When we then follow up to say, okay, well, what happens in the province where they don't start body checking until they're 13, when we evaluate kids who are in a 13 and 14-year-old league? Well, what we see is that overall, we see a protective effect if we just look at the point estimate. So we see the kids who are in Alberta have 15% fewer overall injuries. This is not statistically significant in this study, and when we compare that, of course, to a 3-fold greater risk in the 11 and 12-year-olds, you need to look across the whole picture. And so arguably when you do that and you look at the overall impact potentially of disallowing body checking in 11 and 12-year-olds, you would potentially save over 6,000 injuries a year in just 11 and 12-year-olds. And again, a point estimate, you might have up to 1,000 more injuries in 13 and 14-year-olds. Okay, and so is there an unintended consequence? So what we know is many things, and it's always the answer of all papers. We need to do more research, of course. And so first of all, though, what we did was present this work, and we worked alongside Hockey Canada, and there was a lot of media attention. not so much social media in that year because we weren't there yet. But I would say that the media attention was significant. We had key NHL players at the table. We had Hockey Canada at the table, and we discussed the evidence. And really, it was about the evidence informing a policy change that was national, and that's not the researchers' decision, that's the community partners' decision. So having them at the table for the last 6 years was imperative to this actually moving to a decision to disallow body checking then in the 11, 12-year-old age group. And so this is about research and community engagement, and in 2013 we saw this policy change. And we actually, at that big meeting in 2013, we presented all the evidence. We had all the partners from across Canada. We were in Whistler, and then we created this one-page infographic. And this was the information that was before all the board members at every provincial board meeting, and then at the National Hockey Canada board meeting. And this is actually what led to that policy change, which I can argue has had a pretty significant impact. So if we evaluate that change over time, so we have injury surveillance in place, and we have a significant number of players involved before and after. When we look at all injury, we see a 50% reduction following this policy change in 11 and 12-year-olds or the under 13, and a significant impact as well in concussion. And that's what this translates to, and I think I mentioned that a little bit earlier. So now we start talking about why is it that the brains of 11 and 12-year-olds matter, but not those that are 13 to 17. So lots of conversation about where do we go from here. And we then saw this informing some policy changes which were provincial as well as regional in some areas. And they then had a policy that disallowed body checking in non-elite levels of play. So when we talk about non-elite levels of play, it's still competitive ice hockey, and it's 70% of kids who are 13 and 14 years old now in these leagues. And then when we evaluate that over time, we saw a significant reduction in all injury in this particular age group as well, leading to, again, an impact that was national if this policy were to be scaled up to a national level. And then there's the under 18s. And we saw, again, a significant impact. Again, 60 to 70% of players are in the non-elite levels of play. And we make that change over time, and we see a 65% reduction in injury and 50% reduction in concussion. And so looking at concussions alone in the under 18, we know that adolescents can also benefit from such a rule change. And then the cost effectiveness piece was important as well. So not only are we seeing fewer injuries, but we're seeing lower costs. And this is short-term costs. This is just cost to the healthcare system, but an important piece. And if we translate that up to, this was in the 13, 14-year-old age group, we translate that to a public health care cost reduction of $2.3 million. So lots of controversy, and particularly our neighbors to the east in Saskatchewan, they believe that you should start playing hockey when you're 9 months and you should be body checking when you're 2. And this is written in media, so I didn't make that up. But you can see the quote here. Our view is to start younger, teach it as a skill, like any other skill, and then there's less likelihood of being any injuries. And so we've shown this not to be true. However, what's missing in here is that it's still a skill that is taught. It's just that it's disallowed in games. And so it was important to understand any potential unintended consequences. And so Paul Eliasson, a postdoctoral scholar that I work with at the University of Calgary, he demonstrated that despite having less experience in body checking at a younger age group, there was no increased risk. In this case, he looked at injury in these two graphs in both the 13, 14-year-olds as well as the older adolescents. And in fact, when you see in the under 18, there was a higher rate of injury in those players that had 3 or more years of body checking experience. This is controlling for many other factors that are critical to do so. I'm going to go to a rule that didn't work. So zero tolerance for head contact, it makes sense. Best intentions to try to decrease concussions in ice hockey. penalizes all intentional and unintentional player head contacts to reduce concussion. So we evaluated this because we were doing surveillance across multiple provinces and many different levels. And what you see here is what you think you see, which is after this zero tolerance for head contact rule enforcement, we see a significant increase, more than twofold in some of the age group of concussion. So why would this be? Well, first of all, that wasn't an evidence-informed strategy, I think is number one. I would suggest that there's been a lot of media attention, so potentially greater reporting of concussion. Now we see that more broadly across all sports with a referral bias as well. So more kids are being seen following suspected concussion than they were before. And we went on to see if there were actually any differences in actual head contacts doing video analysis. And we show no differences before and after this policy change that happened in 2011. And here's the key, that there were only about 13% of all head contacts that were penalized despite what the rule was. And that was the same before and after the rule change. And so that was really important for us to then further investigate the impact of refereeing and refereeing behavior. And so what we did was we took a lot of video clips, some of them that were associated with an injury, some not, and some that had head contacts and some not. And what we found was that actually with 100 referees who are refereeing at this level of play, that the sensitivity and specificity of them being able to identify head contacts was very high. But we know that then in a game it's very different, and there's lots of reasons you wouldn't call a penalty in a game. You don't want to disrupt the flow, and so now we go on to do more work with the referees to see how we can address this. And I think implications for other sports is important as well. I am told by many of my colleagues in rugby that if you remove the tackle, you can't call it rugby, and so it's a different game. However, we have a huge problem. I don't know if you remember the injury rates you saw before, the concussion rates, but in this particular graphic, what you see here is on the girls' side, in the under 13, these are 11 and 12-year-olds. They have the highest suspected concussion rate, limitation by video analysis, of course, in this context during COVID. But I think this is a really important thing that we need to address in our country. And these people are the champions. They know the sport, they're playing, they're coaching, they're refereeing, and they're doing all of the work in rugby. We're also going to be looking at potential policy related to the number of players on the field, so player field density. I brought up equipment just from this one slide because I think actually there needs to be policy around equipment if we have good evidence to show a protective effect. Controversial topic, I could talk about it for 15 minutes in itself, but mouth guards in youth ice hockey. And so I would say that, and I know I'm biased, but I would say that this is one of the strongest methodological studies around evaluating mouthguard use. We did both a nested case control as well as a cohort study analysis, which is boring to many of you probably, but it's an important thing that these two analyses actually were consistent in demonstrating a significant protective effect of mouthguards, regardless of whether that mouthguard was off the shelf or a dentist fit type. This is just under re-review in BJSM. Ash Kolstad is leading this work, and you'll hear more about it if you go to Amsterdam. There's other rule changes in other sports. This is our football, and I guess, you know, we're not as maybe aggressive in North America because we wear helmets when we play football, but the sport's also quite different. It's not soccer. And the strategy has been to try to reduce head contacts in practices. So restricting contact practices combined with coach training, we do see a reduction in concussion rates and a reduction in injury rates across a number of sports. This was presented at the last consensus. I'll say that there's much more data now, but I'm not allowed to talk about that yet until next week. In Canada, we use the running time rule. So if there's a score differential in tackle football of more than 35 points, we go to running time instead of stop time. So not a big surprise that we see fewer plays. So we reduce the plays by 24%, and we reduce the head contacts by about 24% as well. And so that's really one policy or rule change that did have some impact. And then during COVID, there was decisions made about changing the number of players on the field. And in doing that, if you change the number of players and you have fewer players on the field, but you also decrease the field size, you don't actually change player field density, which was in this study the biggest issue, I would suggest, but we evaluated it anyway because we were doing video analysis and demonstrate no differences between the two field sizes and number of players on the field, 9 on 9 versus 12 on 12. So what about rugby? Do you play rugby in this country? A lot? No, a little bit? Okay. And so the big thing, and that's been discussed for many years at the professional level, is where should the level of the tackle be? So the maximum tackle height was lowered from the line of the shoulders on the ball carrier to the line of the armpits. And so this is work from my colleagues group in the University of Bath, Keith Stokes, where they found that tacklers contacted the ball carrier's head or neck 30% less often, but tacklers aiming to tackle lower suffered more concussions. So again, an unintended consequence, and we don't know yet the relevance for youth because we don't have good data. How many people here work in the context of management and treatment and rehab? Put your hand up. There's a few physios around. Excellent. Okay, so when I talk about primary prevention, I often stay way upstream, but there's lots of ways we can prevent, and through secondary prevention and tertiary prevention. And this is just to show that over time, some significant attention to education, information, as well as medical intervention and return to play practices, eventually over a 3-year period in youth across the U.S. and many states, they did see a reduction in recurrent concussion rate. We know 30% of kids are going to have a recurrent concussion, so this is an important target as well. So in summary, some might call this the low-hanging fruit. We don't actually have to get them to do anything other than to change the policy and then try to have them adhere to whatever that rule change is. Hence, I call it the low-hanging fruit. We need to scale up surveillance to be able to evaluate these changes, and sometimes these changes happen without any evidence informing the change. So we need to kind of stay up on what the changes in rules are as we go along. And I think that there's some place for management protocols as well. So this work is done by a huge team that I have the privilege of working with out of the University of Calgary, and in collaboration with many other partners across Canada and internationally, and our community partners are key. So thanks so much for your time this afternoon.